is Dr. James Cameron. I am a neonatologist here in Fort Wayne, Indiana, and we're going to be talking about neonatal abstinence syndrome and what physicians need to know about their infant patients to determine whether or not they should be treated medically or just with comfort measures. All babies that are exposed to opiates in utero need to be observed in a special care nursery or an intensive care nursery. Most likely no. A lot of the babies that are exposed will not show signs that are severe enough to require treatment with an opiate. So why would a baby need to be transferred to the special care nursery, or why would the baby need to be transferred to a level 3 intensive care nursery? The reason we would transfer a baby to a special care nursery beyond having consistent scoring mechanisms for these infants is as they're started on an opiate treatment for their withdrawal to reduce the withdrawal symptoms, they're going to be at risk for apnea, decreased saturations, and because of this, they need to be on monitors. So they're going to have their oxygen saturations monitored, they're going to have their respirations monitored, they're going to have their heart rate monitored. And until they've been adequately weaned off of these medications, they're going to have that continued need for monitoring. Breastfeeding is actually a great way to reduce the severity and the symptoms of withdrawal in infants. The breastfeeding is more of a comfort measure. It's true that some of the opiate medication is passed into the breast milk, but typically it's felt that the amount that's passed into the breast milk that the baby consumes is physiologically insignificant, in part because the amount that the baby gets from the breast milk is low, but also as the baby is consuming it, there's this first pass metabolism as it's going from the GI tract through the liver and into the baby's bloodstream. So the amount that ultimately reaches the baby's bloodstream is negligible, and thus the breastfeeding is considered safe and a great way to provide that skin-to-skin comfort measure and the bonding for the family and the baby. Breastfeeding isn't always a good or a safe option for the mother and baby. In instances where the mother's been using other substances, such as heroin, such as cocaine, marijuana, these drugs are contraindicated in breastfeeding because they may pose a risk to the baby, they may pose an additional risk to the mom, or both of them combined. And because of that, we would want to promote the skin-to-skin time with the baby, but would not want the mom to be using her breast milk for the baby. Unfortunately, when a baby requires treatment with a medication for withdrawal, their stay in the hospital is going to end up being longer. The reason for this is because we want to make sure that the baby's symptoms are adequately treated so the baby is no longer having those severe signs of withdrawal. They're still going to have some signs of withdrawal. They may be a little bit more irritable. They may not sleep from one feeding to the next. They may not eat quite as well as they would if they had not been exposed. Ultimately, the goal is to maintain them at that controlled withdrawal state until we can decrease the amount of medication that they're on. Because of that, when we finally get their withdrawal symptoms captured, we'll start to wean that dose over the course of a week to 2 weeks, depending on how the infant is doing. Babies who are exposed to additional medications such as gabapentin, babies who are exposed to tobacco in addition to the opiate, will have symptoms of withdrawal that will last longer, and they can also be more severe. And because of that, sometimes we have to add in additional medications. And as we add in those additional medications, we also want to be able to wean those off before we're discharging the baby to home. Because of this, the range of treatment in the hospital can vary anywhere from 7 days out to past 3 weeks, depending on the severity of the withdrawal symptoms. So there's many different ways to medically treat withdrawal symptoms in the infant. The two most common medications that are being used right now are methadone and morphine. The benefit of using morphine to treat for withdrawal is that it has a shorter half-life, and you can make adjustments and see the impact in a relatively quick manner. The benefit of using methadone for treatment is that it's got a longer half-life, and you're going to have a more steady level in the baby's bloodstream, and so those withdrawal symptoms can be gradually weaned down. Clonidine's an additional medication that's used in the treatment of opiate withdrawal. A lot of times we'll use that not just as a primary treatment, but we'll use it as an adjunct. We use an adjunct medication oftentimes when a mom is exposed not just to an opiate during the pregnancy, but some other medications, whether it's a medication such as gabapentin, or if she's exposed herself to other illegal substances such as cocaine. These infants are more irritable and oftentimes will require a second-line drug. Phenobarbital is another drug that we would use as an adjunct medication in the situation where it wasn't just the opiate that the mom was exposed to, but perhaps gabapentin or cocaine. One other medication that's being used is buprenorphine. Obviously, this is used for maintenance therapy in mothers who are having a controlled withdrawal from opiates. But additionally, there's some programs that are looking at the benefits of using buprenorphine for withdrawal of the infants and treating their neonatal abstinence syndrome. Not all infants will show symptoms that are severe enough to require treatment for withdrawal, but most of these infants will show some signs or symptoms of withdrawal if you're looking for them. The babies that require treatment for withdrawal are the ones that are having symptoms that are severe enough that they can impact their ability to gain weight, their ability to maintain adequate hydration, and also from a neurologic standpoint, the babies that are having problems either with excessive irritability, not being able to sleep. And this all goes together to impact, are they able to eat? Is their mother able to care for them? And are they at risk for having other negative outcomes as a result of that? So a mom that's being treated with methadone during the pregnancy may have to have her dose increased. This is because during the pregnancy, her body's changing. And as her body changes, the amount of drug that she may need in order to control her withdrawal symptoms may go up. It may not, but when it does, she'll end up going on a higher dose. And as it's being metabolized, it also is changing the amount of drug that the baby's being exposed to. As the baby's exposed to these drugs in utero, again, the baby's at risk for having withdrawal symptoms after that drug is withdrawn from the baby at the time of delivery. So methadone and buprenorphine are a much longer acting drug, and they're metabolized more slowly in the body, both in the adult and in the newborn. But there are other drugs that act much more quickly and are metabolized more quickly, such as heroin and fentanyl. These drugs, because they are metabolized so quickly, the baby will show signs of withdrawal in a shorter time period instead of the 4 days to 5 days out to 2 weeks that we see with methadone and buprenorphine. Babies that are withdrawing from heroin and fentanyl can show signs of withdrawal within the first 24 hours. Moms who are in treatment programs using buprenorphine or methadone, or moms that are using illegal drugs such as heroin or fentanyl type medications, if they're using additional drugs, or if they're smoking, or if they're using drugs such as cocaine, these can all impact the amount of time that the baby will show signs for withdrawal. And it doesn't just impact the duration of the withdrawal, it impacts how long it takes them to show those peak symptoms of withdrawal. And so because of that, we may have to watch a newborn for a longer period of time in the hospital before we're comfortable that they're safe to be released and not ultimately going to show withdrawal symptoms that are severe enough that require treatment in a hospital. Babies who are being observed for risk of having severe withdrawal probably should be observed for at least 4 to 5 days in the newborn nursery. If their symptoms are starting to escalate to the point where they're nearing a point where they're going to need to be treated with a medication for the withdrawal, then they probably should be observed for a longer duration. And these symptoms can go well out past a week to 2 weeks of life. For babies who are born to moms who have been using tobacco in addition to the opiate or cocaine in addition to the opiate, these babies are oftentimes showing signs and symptoms of increasing withdrawal well beyond that 4 to 5 day period. And because of that, they may need to be watched for 7 days out to 10 days before we can be comfortable that they're going to be safe to be discharged home. Babies that are at risk for withdrawal, we're going to want to watch them for the symptoms that will impact them as they're getting close to being discharged. The symptoms that we want to watch for are going to be symptoms that affect the neurologic system. They're going to be symptoms that affect their gastrointestinal system and several other physiologic components associated with the withdrawal that can lead us to want to treat the baby to decrease those symptoms. The symptoms that we're going to be looking for are oftentimes scored in a scale called the Modified Finnegan scoring system. And with that, we will score them for symptoms such as diarrhea, for emesis or vomiting. We'll score them for jitteriness, for an excessive moral reflex, for an inability to latch on to the mom while they're trying to breastfeed, or to be able to latch on to a bottle or a pacifier. All of these are signs that the baby's neurologic system is in overdrive from these withdrawal symptoms. So other symptoms that we'll be looking at that address the neurologic symptoms with the fussiness is the babies oftentimes are moving excessively, and it's not just the excessive rooting or the excessive startle reflexes that they can have, but because they're moving their hands and their feet, because they just can't settle down, oftentimes they're going to end up with excoriations or injury to their skin from rubbing it against the surface. So we'll score them for signs from that as well. The gastrointestinal standpoint, we're going to be looking at their vomiting. So if they're having multiple episodes of vomiting, then they will be scored for that. If they're having loose or watery stools, they're going to be scored for that as well. Babies should be considered for transfer to a neonatal intensive care unit for closer observation when their Finnegan scores are approaching having 3 scores of 8 in a consecutive scoring period, or 2 scores of 12 in a consecutive period, or 2 scores that average 12 over 2 consecutive scores. The reason we want to have these infants transferred to an intensive care nursery at that point is because these staff are often the best trained at being able to watch for the signs and symptoms that would require treatment with an opiate. Beyond the neurologic findings that babies are scored for, there's increased temperature that they're going to be scored for, decreased sleeping periods that they'll be scored higher for. And again, all of these go towards that score of 8 or 12 or 14. And the higher the score, the more severe the symptoms are, and the more likely that they're going to need to be treated with an opiate. Beyond the Finnegan scoring system or the modified Finnegan scoring system, there are many other scoring systems to use. One of the new ones that's being evaluated in some research trials is the Eat, Sleep, and Console method. And what this does is it treats the baby more as if it is just a baby. So the babies should be able to eat, they should be able to sleep in between feedings, they should be able to be consoled. And unfortunately, babies who are going through severe withdrawal and babies that need to be treated with an opiate will not be able to eat enough volume in order to gain weight or to maintain their weight. And that's because of that excessive rooting that they're having, because they're having a lot of excess regurgitation or vomiting. They're not going to be consolable. Their neurologic system is so irritable that even with swaddling, even with decreased lighting, even with using soft voices, even with the breastfeeding, which is more of a consoling mechanism than like a medication treatment, these consoling methods are not enough to be able to console this baby that's having severe withdrawal symptoms. And that baby probably needs to be considered for some aspect of treatment with the medication. When the baby's in the newborn nursery, a lot of the mechanisms that can be used to prevent or to reduce the severity of the withdrawal symptoms are these sort of comfort measures. The comfort measures are the swaddling, the decreased lights, the soft voices. Breastfeeding. Breastfeeding is a great way to give both skin-to-skin contact for the baby and the mom. It also provides an improved bonding experience for the mom and the baby when they're going through this really difficult period, and reduces the chance that the baby's going to need to be treated with an opiate medication to lower the symptoms of withdrawal. So as we're getting ready and getting close to discharging the baby from the NICU or even from the newborn nursery, a lot of the parents and physicians expect that the baby's going to be symptom-free from withdrawal at the time of discharge. And unfortunately, that's not the case. Infants can show signs of withdrawal for several weeks after discharge from the hospital. The goal isn't to get them withdrawal-free, but it's to get them to a point where they're able to, as we said previously, able to eat, able to gain weight, able to be consoled, able to be sure that when the baby goes home, it's not going to be so irritable that the baby's at higher risk for being shaken or have non-accidental trauma. So babies that are at risk for withdrawal are going to be more irritable. When the moms and dads are taking these babies home, they need to understand that these babies are going to continue to be irritable at home, and because of that, they're at risk for shaken baby syndrome. The parents need to have good education, strong education, to know what their resources are, to know what they can do to reduce these risks to the baby and to themselves. It's okay for the baby to be left in the crib to cry, for them to walk away, for them to call and ask for help. They need to know what their resources are when they're discharged to home, because these symptoms can be severe even the first night of discharge, and nobody knows what point it is that they're going to have that event that pushes them to shake their baby, and we don't want any family to have to go through that. Babies that are exposed to opiates in utero, whether they're admitted and discharged from the newborn nursery or whether they're admitted to the neonatal intensive care unit and they're discharged from there, as they're discharged to home, they're going to need to be followed by their primary care physician to watch for symptoms to make sure that they aren't becoming more severe and that they don't need to be readmitted to the hospital, that the parents don't need additional coaching to avoid shaken baby syndrome, to make sure that the baby's gaining weight well. But beyond that, babies that are being discharged from the NICU that have been treated with an opiate, these babies are at higher risk for having developmental problems as they get older, and they're going to need to be followed in the developmental follow-up clinic or the NICU follow-up clinic. So what babies do we need to watch for neonatal abstinence syndrome? It's going to be any baby that's been exposed in utero to an opiate, whether it's a medication that the mom was prescribed for treatment of acute or chronic pain, or for moms that have been using illegal substances such as heroin, such as fentanyl, or illegally using prescription medications. All of these babies are at risk for having withdrawal symptoms. In addition to the drugs that the mom may be taking illegally or the prescribed medications that the mom may be taking, some women are taking drugs for maintenance therapy programs such as buprenorphine and methadone. And although many of the families think that the baby isn't going to withdraw from these medications, the babies are actually at risk for having withdrawal symptoms, and the family should be aware of that as well as the physicians prior to the delivery of the baby so that the expectations can be set for the family and for the physician, and so that the families will know ahead of time what symptoms they should be looking for following the delivery of the baby. So when we have a mom that comes in and delivers and she's been in a maintenance therapy program, one being treated with buprenorphine or methadone, many times we want to see these families be successful, not only with the treatment program, but also being able to take the baby home and have the baby and the mother bond successfully. In order to be successful in discharging this family home together as a successful family unit, the planning for the delivery needs to happen before the baby is born. So early on in the pregnancy, while the mom knows that she's pregnant and she's in her treatment program, she needs to have the understanding of what to expect when she's going through the pregnancy. How is her need for the medication going to change over the course of the pregnancy? How is her baby going to respond to it? And a lot of times the moms are told that they shouldn't expect the baby to withdraw, but all babies are at risk for having symptoms of withdrawal, and both the physician and the mom need to be talking about this before the baby delivers. After the baby delivers, the mom needs to be watching for these signs that hopefully she's been educated about before delivery so that she can help the nurse and help the physician look for these symptoms and be an advocate for her baby. By doing this, we can build a successful family unit between the mother, hopefully the father, as well as the infant, and have them have a successful first year of life. Throughout a pregnancy, a mom is going to have verbal questionnaires addressing the potential use of opiates during the pregnancy and before the pregnancy. In addition to that, some moms will be screened with urine drug screens. At the time of delivery, the baby also may be screened with either a urine, meconium, or umbilical cord testing. The urine screening will go back a week to several weeks before the delivery. The meconium testing and the umbilical cord testing can go back into the second trimester and look for exposures. Even the moms that are in treatment programs need to understand that their baby's going to be tested with meconium, urine, and or umbilical cord testing. But again, this is all to try and provide a safety net, not just for the mother, but also for the infant. And the goal is always to try and keep that family unit together in the most safe environment that's possible.